So let's move on to the clinical geneticist and rare disease expert Gareth Baynam. Professor Baynam seems to be a networking athlete. He's involved in so many networks and institutions and also holding a lot of positions there. And if there's not enough networks, he will start another one. Really passionate about helping rare disease patients to obtain a diagnosis. He says himself that he's partnering at the speed of trust. I think this is a very nice phrase. Partnering at the speed of trust to improve the lives of people living with rare diseases. And he's also really aware of the inequality when it comes to achieving a diagnosis. And he truly feels that if we cannot provide a diagnosis for everybody that needs it, then we cannot solve this. We cannot obtain the global goal of ending the diagnostic odyssey, because it truly is an odyssey for many of us. Also, he points out that when finding out these solutions, this will benefit all of us. So please, I welcome Gareth Baynam.
Thank you. Thank you so much for that very gracious introduction, a pedestal from which I will now fall very rapidly. Most importantly, hello to everybody. It's such a great honour to talk today, and a massive virtual hug to all my old friends and new friends in the real and virtual worlds. You'll see on the slide here a painting. This is a painting done by a whole family in an extremely remote part of Western Australia in the desert, as that family learns through the family and through their youth about genetics, and how that family describes how genetics really resonates with the narratives of their community. And I'll talk more about that as we go through. So I'm talking to you today from the banks of the blue waters of the Swan River in Western Australia, and the Aboriginal custom is that the woggle, a great serpent, writhes through the lands to create this beautiful Swan River. I look forward to when the COVID restrictions are raised and I can also move down to further parts of our state in the beautiful waters of Esperance, where it's not uncommon to see kangaroos resting on the beach. Or perhaps also to visit Rottnest, a small island off our coast famous for its quokkas and for its selfies with quokkas, including with famous Europeans such as Roger Federer. We're a really quite massive state, and most of it is made up of red sand, and you can see that from the diagram here. The little circle at the top is the Pilbara, and Port Hedland specifically, and we'll talk more about that as we go through. We're about a quarter of the size of Europe, or travelling from Perth to Port Hedland is equivalent of travelling from Stockholm to Vienna. We're very fortunate to over the last number of decades increasingly have a number of clinical services, data sets and policy units really centred to improving the lives of individuals with rare conditions. And this gives us, as was put by Anna, with a great sense of opportunity and responsibility. Some of those include services within our health department, and others include those in primary care, including those focusing purely on Indigenous primary care. Now, 50 years might sound like a relatively long time, but in the context of 60,000, it's tiny. Why 60,000? Well, Aboriginal Australians are the longest living oral culture, dating back 60,000 years. And why language? Well, really, language is just so fundamental to everything we do. But you don't need to take my words for it. You can read Nelson Mandela's. Or you can read words from one of our Aboriginal elders. Very succinctly, language is culture. Language is also memory, or in fact, a memory code. We have different sorts of memory codes, different sorts of life languages. Our genetic memory code, our genotype, the set of instructions for us and how we pass inherited information down to our offspring. Equally, it's a way of storing information. For instance, Wikipedia has been encoded into DNA. And apologies, I've just lost the navigation buttons on the side of the screen. So I'm going to try to find them. And here they go. Or other memory codes, other life languages, our phenotype, our oral and written stories, what we tell each other, what we tell our doctors about our health. Equally, these memory codes can also be in turn turned into their own codes for memory. Or the memory in our lands, in our environment, in our skies, in our stars. Again, in Aboriginal culture, there are things called songlines, and you can see an artist's representation of a songline traversing Australia. These songlines are sung by men and women to pass on information to their children. They are sung differently by men and differently by women. They are wrapped around physical structures and around astrological structures to help retain and package that information. Perhaps this reminds you of something, of genes, of DNA, transcribed differently between men and women, wrapped around structures to maintain their integrity and package them, such as histones. Please read this book. I think you'll find it fascinating. Anyway, back to my work as a clinician. And as with everything, it starts with a family. So in around 2006, we were doing some testing for an Aboriginal family who had a child with a terribly devastating condition with intellectual disability and multiple congenital abnormalities. We found a change in that gene, but we couldn't be sure that it was the cause for that condition because we just didn't have a map. We just didn't have the reference data to compare it against. Based on this and other factors, we then had lots of discussions with various health leaders and community members, including our senior Aboriginal leaders group in WA Health. Also, as things evolved, we really wanted to continue to raise the awareness about the needs to improve genetic healthcare delivery and rare disease diagnosis and care for Indigenous people and, in our country, Australian Aboriginal Torres Strait Islanders. Again, it continued with the family. In fact, our first ever use of clinical use of whole exome sequencing in 2013 was for an Aboriginal family from remote Australia. This time, only 7 hours drive from our capital city. These are the three siblings. Again, they had multiple congenital anomalies and intellectual disability. We had tried everything to get a diagnosis for these children and their family. You can imagine what it would be like living with three children with that combination in a remote community. Ultimately, we found a variation in a gene, and again we were left in the setting where we had no map, no reference data to compare it against. So after 8 years, we had a very strong clue as what it was, but it took us 2 years of further work to prove it was the cause. 2 years of work that we never would have needed to do in a Caucasian family. We would have had that answer straight away. Ultimately, this family's discovery has gone on to unlock answers, diagnoses for many other families around the world. So really a gift from this family, from the very most remote parts to the rest of the world, a gift that continues to transform knowledge. Importantly, this was not just about getting an answer for all the certainty that brings, but also the answer provided an opportunity for drug repurposing. That is to use a new medicine for a different indication, a new medicine to treat their intractable seizures, a new medicine potentially to treat their cancer, as by virtue of this condition, they have an increased cancer risk. Things kept evolving. We also needed to better understand the phenotypic languages, in this case, facial languages. So we embarked upon trying to understand what was the normal range of information in terms of 3D facial structure to help diagnose and to help monitor treatments. So we started in the Western Desert. We then brought together people around rare diseases and Indigenous genetics for our Human Genetics Society of Australasia meeting, recognising the shared themes of equity. We moved on to implement the much needed reference data, or at least the initial set. Very fortunately, Telethon Kids Institute here in Perth had done research generating some reference data. So we were able to quickly flip that information into our public health system lab to then use it and then to make it available through a data access committee for others in Australia to use. We progressed on for a broader understanding and a more community engaged understanding through partnerships with the Roy Hill Community Foundation, the Perth Children's Hospital Foundation and others in the Pilbara region. That little red dot that I showed you up at the top of Western Australia earlier. And really these gave new ways to engage people around health, to engage people around rare diseases, to raise awareness as well as build new solutions. One of the products of the facial analysis work was face language. In this case, taking a 3D facial image of my daughter and then extracting terms, text terms, words that can be written down, words that can be used in analytics combined with other technologies, words that can be used to better interpret genetic testing. These standardized words, these human phenotype ontology terms, are extracted and we can see that they're graphed to see whether or not they fall within the normal range. It continued with further families. So about 4 years ago, we started our undiagnosed diseases program for our most diagnostically challenging cases, for those children that were the most intensive users of our health services, that were rotating round and round the community, round and round the hospital, seeing many specialists without an answer. On reviewing this 4 years later, 1/4 of our patients are Aboriginal and 1/4 of our patients are for remote and regional areas. That's not because rare conditions are more common amongst these groups, because they're not. It is because they have much more challenging health journeys. So instead of having their diagnostic odyssey ended at an earlier stage, they have a more protracted odyssey and end up in what can be seen as an end-stage program. One of the other solutions generated through serving the need of an Aboriginal family in this program was creating an international data exchange mechanism. On the passage towards diagnosing a girl with a rare type of Russell-Silver syndrome led to the development of an international way to exchange data, both genetic and phenotypic data, which we work together with Japan and with the great work of Tudor Groza here highlighted, delivered that in 48 hours. It stimulated service improvement and capacity building, research and programs into how do we better engage with, how do we better work together with, how do we better deliver care for Aboriginal patients and families, capacity building and clinical genetic counselling for Aboriginal health, Aboriginal cadet positions so that Aboriginal young people were developing skills in genomic policy and clinical care, the inaugural Precision Public Health Fellowship in Rare and Undiagnosed Diseases, and the Life Languages Project, which flowed out of a number of those initiatives and critically supported through Roy Hill Community Foundation and the support through the Andrew Wright Bennett Foundation, the McCusker Charitable Foundation and others. So why languages? Why Indigenous languages? Why rare diseases? Well, purely on numbers, There's about the same number of people speaking an Indigenous language as there is suffering with a rare disease. And there's about the same number of Indigenous languages as there are a rare disease. So why not? So the Life Languages project is to retain and empower language. It's to create more connected communities, because it really is about intergenerational knowledge and culture sharing. It's about fusing ancient and old knowledge with the latest technology. It's enacted through Life Language champions, youth that connect with their elders, with their senior people in their family, and with other youth to do this work together. Youth that represent medical students, allied health students, language teachers, artists, professional sports people, all working on a number of languages with a common goal. This is our first Life Languages champion, Yalalu Thomas. Yalalu was the first person in his community to complete high school and then went on to do medical school. He's been working with his family, and you can see here in the block. So you need to fly 3 hours to Port Hedland and then drive another 3 hours to get to the block to do translations of Nyangamata Aboriginal language. He's also been working on a number of other related initiatives to improve care delivery. A remarkable young man who was awarded the WA Young Australian of the Year for his work. Technically, we're converting medical terminology into lay language and then into computer-readable terms. So you can see here, for instance, macrocephaly, which in lay language is big head, or in Nyangamata is Jentu Wertu, then through to the HPO term, the computer-readable term, HPO 40256. This has also opened up discussions about genetic healthcare, about rare diseases, and delivering it in concepts that resonate with the Aboriginal narrative. So this is some of Yalalu's handiwork after discussions with his community, using the concepts of songlines and singers to explain concepts of inheritance, genes, and rare diseases. Equally, some unanticipated benefits. As we've seen this amazing network of youth and elders flipped, pivoted to things like COVID. So when COVID hit, it was critical to have information in language for communities to educate about how to best respond. So using this network in 48 hours, multiple Aboriginal languages resources were created and implemented in the community and became part of the WA Health suite of responses to COVID. Rare disease, helping people with more common conditions. This is Shamir, another Aboriginal medical student and a remarkable young man whose family has an amazing story. And you can read here what this project means to Shamir. These youth are network generators. They create incredible connections far in excess of what anyone else could do, and in the most culturally appropriate and sound ways. Truly remarkable. Again, at a technical level, this enables the fusion of languages, face language, text language, and therefore natural language processing and artificial intelligence, genetic language, to create more equitable and personalised analytics, to get answers, to get diagnoses, and to inform medical care. The community impact expands and now has led on to new types of healthcare worker positions in the community that are now planned to partner through to service delivery. We're also seeing the international partnerships, including in Africa with Rare Diseases Ghana Initiative and others. Immediately before this talk, I received a remarkable email from Rare Disease Ghana Initiative about how they're progressing this with an amazing combination of skill sets. I look forward to sharing that soon. So the vision, the hope and the action is to combine the voice of the people, the voice of the Indigenous Indigenous people, the voice of the doctor, orthodox medical knowledge, ancient wisdom, and new technology to deliver answers, community, trust, and empowerment. Or put another way, it's AI squared. It's where ancient intelligence works together with artificial intelligence to improve health. Thank you.